Does this move? Ah. So I've got no financial disclosures. I myself am trained as a hepatobiliary surgeon from the UK, and I work at Shaukat Khanum Memorial Cancer Hospital at Peshawar. Um, the objectives are going to be to talk about the basics of artificial intelligence methods that are being utilized and its role in diagnosis, treatment, and surveillance of this disease. What I'm also going to briefly touch upon are the various controversies that we face or are we going to face when it comes to artificial intelligence. Now, I've kept it brief because I know the audience is mostly medical students here, but it's going to be slight detailed discussion at the same time. What I'm not going to talk about is robotic MIS, distal pancreatectomies, benign disease management, and so forth, because I think that is out with the talk of my representation. So, basic terminology, artificial intelligence. So, when we talk about artificial intelligence, it's an umbrella term. So, this is just like we say there's Pakistan, and then Pakistan has KPK and Punjab and Sindh and Balochistan. The same thing is with artificial intelligence. So, it's an umbrella term, and what it essentially means is technology which mimics humans. It could be a cognitive function replication, but the computer just does it at a much rapid and faster rate than the human brain. So that's what essentially artificial intelligence means in a nutshell. Now, it can be further divided into machine learning. Now, this is the basics of AI when we talk about various systems and things in place at the moment. And what it essentially does is we feed the computer certain patterns which it then recognizes at a much faster rate than the human brain. The problem with that is it has to predict similar patterns. So if there is no pattern, the computer doesn't know what to do with it. That's where deep learning comes in. So deep learning is part of artificial neural networks. Now, if anybody remembers the Terminator film back in the 90s, I don't know if you were all born in the 90s or not, but for those who remember that, the computers was able to think for itself. It was able to make its own decision, and it was fairly independent and required very little supervision. That's where deep learning comes in. So that's the next stage of artificial intelligence, and that's where the world is moving towards. So I'm going to start with screening for pancreatic cancer first. Now, there was this paper published in 2021 in which they looked at this part, the utilization of AI, to see if they can screen a larger population for pancreatic cancer and using machine learning techniques. What they did was they looked at patterns in families and in those patients who had hereditary pancreatic cancer, and then they looked at them over a period of time to see if machine can predict whether some patients are going to get pancreatic cancer or not. So this was in 2021. There was around 1,139 patients. It was a case control study. So if for those who remember their community medicine or studied community medicine, they would know what case control studies are. And the machines were able to predict with 72% sensitivity 43% of the high-risk patients almost 20 months earlier that these patients are going to get pancreatic cancer. So this made a lot of news back in 21, and people were quite interested in this. There were some problems with this. First of all, in the Western population, inherited pancreatic cancer is only 10% of the population. Some might argue that it might even be less than that. Is a huge number that are needed to be screened in order to pick up one pancreatic cancer with this. And the other problem is most of these patients are asymptomatic, and apart from having familiar history and some high risk behaviors, there's not much else which you can feed the computer. So if you were to take this and kind of spread it over a big country with 240 million population, the cost alone of implementing this is just going to be huge, and the benefits might not even be there. So don't believe everything you read. But so if we can't screen pancreatic cancer with AI, can we detect pancreatic cancers earlier. So that's probably going to be more appropriate for our part of the world. Now, this is shocking news. When I was making this presentation and I came across these statistics, I got worried as well, because what it essentially says is, as human beings, and you've been trained in HPB as a radiologist, and that's all you do in and day out, you'll still miss 40% of pancreatic cancers in your routine work, right? Now, that's for trained HPB radiologists dedicated to that field. We're probably missing a lot more than that, because we're generalists, you know, and things are slightly different here. I think somebody's mic is on. Now, the thought process behind this was, if you reduce this number of patients that you're missing at early stages, would we increase the survival? Because we all know that pancreatic cancer, that's fine. So we know that pancreatic cancer, when it's picked up early, may result in better prognosis. And once you go beyond a certain stage, it's a futile attempt. You know, you're trying to prolong life. That you're not trying to cure this now. So Harvard came up with this study in which they looked at an AI tool. They came up with this idea that it will detect almost 2 years before any human being can detect pancreatic cancer. Again, made huge news. But when we looked at the paper itself, it was the high risk features in those patients, i.e., they were having exocrine dysfunction, they were having endocrine dysfunction in their 50s. So, diabetes at the age of 50, you need to start thinking about pancreatic cancer as well. And there were other high risk features with these patients as well. So, essentially, the high risk features were being picked up by the computer, and then the computer was predicting these patients will get pancreatic cancer 2 years down the line. Again, big news. It was all over the newspapers. Multiple news channels were covering this. CNN came up with this. Fox News, as usual, came up with this. And they were using this AI technology called radiomics. Now, just briefly to explain to you what radiomics is essentially you take almost 1,000 or 10,000 computer images of pancreatic cancer of various patients, and you feed it into the computer, and the computer then makes these little kind of changes to the pancreas, and then it tends to recognize those patterns, and then when it sees them patterns again, it kind of tells you, okay, this might be pancreatic cancer. Another study was done using the same thing
and figure out which features are most critical for your specific problem. We did this in the past with pancreatic cancer, normal patients.
Mute the presentation. Let's go mute.
And the way you have to think about it, looking at these radiomics features were
mute. Presentation. Background. Sure. Sorry, apologies about it. So, right. Okay. Sorry. Right. So they used this radiomics images over a thousand or so patients, and then the computer was able to predict where the pancreatic cancer is. And the same paper from Taiwan said the same thing. So they looked at pancreatic cancer patients, and then they came up with this program which could predict apparently 2 years earlier than human beings. But here's the problem. In the Taiwan studies, AI missed, again, this is where the big news was, 1.7% of the cancers, whereas the human beings who were looking at the same imaging missed 7% of the pancreatic cancer. Now, on the face of it, that's a huge difference, but when you actually look at the numbers, they were not that high. There's only around 7 to 10 patients that were missed by the human beings. But that difference disappeared when it came to less than 2 centimeter tumors. So essentially, your computer is no better than a human being at picking up small tumors. So the problem then stays the same. If you cannot pick up the smaller tumors, you're not going to get a better cure. So does this program then actually help us in predicting pancreatic cancers earlier or not? Now, The Taiwanese program then got implemented on the US data, and it couldn't perform at all, or very badly at least. So what essentially that shows is that even with the most advanced, well, not advanced, but your current machine learning programs, taking up pancreatic cancer at early stages is still a challenge. So again, not as great a news as it was projected initially. So essentially, this is the picture of a pancreatic cancer, and this is what the machine is picking up. So that's the pancreas, that's the tumor there. This is the non-AI image generated picture. And if you look closely, even the human can pick up that tumor right there. I'm sure you can all see that. The computer is picking it up, but so are we. So bigger tumors, does the computer actually help us get better diagnosis? I'm not 100% convinced at the moment. And so moving forward. So this is an endoscopic ultrasound image of a pancreatic cyst, and this is where it might be helpful at times. So this is an US guided image. That's a pancreatic cyst, and the computer is looking at normal parenchymal tissues and the cyst which is in blue, and then it picks up this red tissue, which essentially is saying this is pancreatic, this could be tumor. So the US with AI technology might help you differentiate between cysts and other things on the spot. So this is where there is a potential role for it. So detection 50-50, surveillance probably not. Can it help us with resectability? So this is what we are already using. We use computer generated images to decide on resectability. Now when we get a 3D image from the computer, you can move the images in various directions, and then you can look where the artery is, and where the vein is, and whether it's involved, whether it's not involved. So that's already in use, and it is very, very, very helpful. So this is one thing I'm sold on, that this is probably going to help us in deciding what to do for our patients. And again, most of the study shows there is 100% accuracy in it, but there's this one small teeny problem which does still irritate me about this, and that is borderline resectable tumors. The problem with that is we as human beings across the world cannot decide on what's the definition of borderline resectable pancreatic tumor. The Americans will say something else, the Koreans will say something else, we in Pakistan will say something else, and in America, the West will say something else, and the East Coast will say something else. So it's all over the place. So if we cannot decide on what borderline resectable tumor is, the data that we feed the computer is probably going to be very confused as well. So there's some little bits that confuses me about it, but I think it's working there. So thirdly speaking, can it help us predict complications? Now this is important because pancreatic cancer has got, according to some studies, 70% morbidity if you can include everything that the patient experiences, and the serious morbidity complication rate is around 50%. So that's a very huge complication rate. That means 1 in 2 of your patients is going to get some sort of a complication, and out with very specialized centers, the mortality is very high associated with it as well. So can we use computers to help predict which patient is going to do well and which patient cannot do well? And we can, but we're already doing this now. So the most dreaded and the feared complication of the pancreatic surgery is a pancreatic leak, because that is essentially can potentially be a death sentence for the patient. But we already have a lot of mathematical calculations which predicts pancreatic leak rates. So your duct to parenchyma ratio, your fistula risk scores, and so forth. So essentially, the computer is doing the exact same thing that we've been doing, but we've been doing it much cheaply because we just look at the computer image, we measure the duct using the computer program, and then we measure the parenchyma, and we divide the two, and that gives us a score. So the computer is doing that as well, but it's going to cost you a lot of money to get that same program. So unless we come up with a better prognostic machine program, I think we're going to be better off doing it on our own at the moment. The other problem with this is all these algorithms need data to predict things. Now, all this, now in this study as well, when you look into it in detail, the perioperative or the intraoperative details that the machine was inputted with couldn't come up with a decision for you. So the computer needed your post-operative data to predict whether you're going to get a fistula or not. So for me, that's then irrelevant, because if I'm going to look at the post day 2 or day 3 amylase level in the drain and it is high, I already know this patient's got a fistula. So what's the computer telling me extra with this? So again, unless and until they come up with something more significant, which can tell me pre-operatively which patient is going to get into trouble, I'm not going to invest my organization's money in this. So here's the truth about AI. So when you're first starting off in your career and you don't have that much of operative experience, you're not battle hardened, जंग में अभी नहीं गए, गिरे नहीं हैं 10 दफा, so you probably will be benefiting from AI. It will help you predict your patients. It will help you decide which patients to take on. It will tell you which patients to avoid taking on, and so forth. But once you gain that experience of, say, you do around 50 to 100 pancreatectomies and so forth, does it really help you after that? Because your experience is going to tell you what to do. What we need is something like the Tesla driverless car, which is autonomous, which makes its own decisions, and you can just sit at the back, have a cup of tea, coffee, and not worry much about it. We're not there yet, but we are getting there. Um, there's huge projects across the world with a lot of money being put into it by the tech companies, Google and so forth. They're looking at populations, they're looking at clinical diagnosis, machine learning, neural networks and so forth. But I think we're at a very early stage of all this. So far, yes, it's AI, yes, it is machine learning, but the data that feeds these machines is being put in by human beings. So we are giving the food to the computers, and the computers are then mimicking what we did. Not sure they're doing a good job, but it's like Professor Irfan said earlier, you had that one person who's not doing the work but taking all the credit. So that's what AI is doing right now. We human beings are putting all the work into it. It's taking the credit for us, but we're still doing the work till this gets automated. Now, I don't know when that will be, but whenever it is and it gets automated, where you do the scan, the machine picks it up for you, it tells you this patient is probably got cancer, you need to be involved in this. I'm not buying into AI at the moment, personally speaking. The problem right now is, like I said in the beginning, your pancreatic cancer is heterogeneous, it is asymptomatic, we don't have any set patterns in it, we don't know who's going to present with pancreatic cancer, we don't, unless until they get those barn dose features, and by that time, in 80% of your patients, it's too late. So unless until we get into a stage where at a population level or at a community level, the machine is going to do the work for us, I'm not buying into it. Why can't we put data into it, and why we not automated yet? When I look at my colleagues' notes for the patients, they use a different word, I use a different word. Another colleague who might be a medical officer might use something completely different, and all three of us mean the same thing. So the computer needs to have a standardized program and language for it to work. So if we can't standardize our own language, एक पश्तो में बात कर रहे हैं, एक पंजाबी में बात करेंगे, सिंधी में, तो हम भी कंफ्यूज हो जाते हैं कि यार ये क्या बात कर रहे हैं, वो क्या बात कर रहे हैं, तो कंप्यूटर को क्या पता चलेगा? And then you need huge data for this. Now, we don't even have a cancer database which is robust at the moment. And in America, they're facing trouble with this because the West Coast and the East Coast data is very different, and the databases are different and so forth. And they're pouring billions into this. So if they can't make it work up till now with billions, I'm not sure we are ready for that, at this stage at least. And the biggest question then arises, we're going to buy Da Vinci robots when we've got problems like this to sort with. So resource deficiency is a problem, and we have to kind of face that. We've got a shortage of skilled staff, so there's not enough HPB surgeons in every district. So we probably need an HPB surgeon in most district hospitals, if not the tertiary ones at least. There's a problem with infrastructure, there's a problem with equipment supplies, there's a problem with budget. But there is hope for us because we can pick and choose the things which are cost effective and apply them in our settings. We can use population-based programs, we can use image-based programs which are cost effective and we know they work. So I think if we pick and choose what we do, AI might be beneficial for us in this part of the world. Thank you very much.
So in 2022, $40 billion were invested in AI. This has increased to $50 billion in 2024.
And AI-related economy will expand to $1.63 trillion in next 10 years. So this is a huge financial finance involved, and every aspect of life will be affected. Yes, there are challenges. There will be ethical challenges. There will be administrative challenges, and the data quality will certainly matter. And all of the people will be developing different applications on different formats. One will be on Oracle, one will be in C++. So there will be